Welcome to everyone who is joining us for our webinar today. We will be starting up right at 2 o'clock, so we've opened this up early for people to join to make sure they're in the right place. But we will be starting in just a couple of minutes, so do bear with us at the moment. Thanks again to everyone who has joined us so far. We will be starting the webinar in just another minute or so, but thank you for your patience. Right, so I've got 2 o'clock, so let's officially begin. Thank you everyone for joining us today to talk about public health and policy reform. We're going to be discussing ideas around mitigating the increases to the state pension age. A few housekeeping things for me to go over very quickly. Of course, we are all hopefully getting used to this new normal we're in at the moment with lockdown. So I'm sure everyone's aware of some of the issues that can affect internet connections and the consequent effects on sound and video. So if we start to have problems, please do bear with us. We've been lucky so far, and hopefully today won't break that luck. Also, you should see at the bottom of your screen with the Zoom interface here, there are functions for you that you can use as participants on the webinar. And the main one to pay attention to is the Q&A function. This will be where you can submit questions you have for me and the other speakers as we go along. And when we get to the final half of the webinar today, I'll start going through those, curating the questions with our speakers, and we'll start to get some answers for everyone. If you do have any issues with audio or video, do use the chat function you should see there at the bottom to let us know, and one of my colleagues should try to should be able to help you out. And if you do get disconnected, you can use the same link from the joining email to rejoin us. We invite everyone, of course, to help us share this on social media. So with Twitter using the ILC UK handle, but also the hashtag MISPA hashtag for the event. So for those of you, just briefly, who may not be as familiar with our organization, ILC, we are the UK specialist think tank on the impact of longevity on society and what happens next. So we're able to look at evidence-based research to inform policy. We're strengthened in this because we are an independent think tank and therefore also politically neutral. And a lot of our strength comes from being able to work collaboratively with organizations from across various sectors to pioneer solutions for the future. And our work at the moment, we have really wanted to try to streamline thinking around longevity and what longevity means for society and for policy. And there are three primary areas we work in. One is to emphasize how to maximize the benefits of longevity, shifting some of that negative narrative that's been rather pervasive about aging onto how do we turn this into a positive and make the most of this wonderful achievement that we've made in human society. Also, needing to look at how to ensure longer lives are good for everyone. There's extensive diversity and growing diversity amongst older populations in every country. So we need to make sure that as we start to think about solutions, we're not overgeneralizing on the basis of age. And this features into what we can do to future-proof policy and practice so that the decisions, the approaches we take today to prepare for the future aren't based solely on experiences of the past, because we know that people in the future will look different than they've done in the past. ILC has a partners program, and I'll tell you more about that at the end of the webinar, but this is, we want to just explicitly thank our partners who, through their support, have allowed us to have this webinar today. So I am Dr. Brian Beach. I'm a senior research fellow at ILC, and I will be chairing today and leading my esteemed group of colleagues to talk to you about some of the work we've been doing on this issue of state pension age. Most people will be aware of the fact that there have already been increases to state pension age over the past decade, and there are further legislated changes laying ahead. Now, we as a group, working on MISPA, we're an informal group, and we really wanted to try to think about what some of the potentially unintended consequences are as a result of these policy changes to the state pension age, and what this might mean for public health and in other aspects of policy, so that we're not implementing a policy blindly. There are, as you'll hear, a number of different impacts related to the NHS, to social care, the voluntary sector, and older people themselves. So we need to make sure that we're preparing for these impacts in order to mitigate them. And in the current context, I think a lot of this is very much underscored by the realities of the COVID-19 crisis. So you'll be hearing from a number of my colleagues today. So on your screen now is the full list. So you'll be hearing from Mel Bartley at the end of our webinar, and we'll be going through hearing from Professor David Blaine, Dr. Claire Maudit, and Dr. Jessica Sheringham. Dr. Jenny Lyle has been an important member of our group, very helpful in contributing a lot from her extensive work in public health and in particular on occupational health. But given her role, she's actually a bit on the front line helping to fight COVID-19. So unfortunately is unable to join us today. Now, I wanted to start off with something that may be to just test everyone's thinking. So I'm putting up a poll on the screen now that is just, do you, for yourself, do you know what your state pension age is? Do you have do you really know when it comes time to take your state pension age, what current legislation says for you? As I've mentioned, there are different changes scheduled. Some have taken place, others will come, and unless the legislation changes, we'll see an increase. So for you out there participating in this, do you have a sense of your own state pension age? So I'll leave it open for just a few more seconds in case other people haven't voted. And I'll be closing it about now. And as you'll see, vast majority of you know your own state pension age. That's very, very good. Now here comes something that might be a bit trickier, is actually, what is the state pension age today? For someone who is eligible as of today, what is their state pension age? So I'll leave this open because it's a bit longer than a simple yes or no question. And I see lots of votes coming in. We've got just over half of you voted so far, so I'll leave it open a little bit longer. About 5 more seconds. So get your votes in now. Okay, we'll close it. And the good news is that the correct answer gets the largest proportion. So it is actually none of the above. Technically, as of the 6th of May, the state pension age was 65 and 9 to 10 months, depending, it's all birthday based right now as we're shifting to when it will be 66, both for men and women in September of this year. But that's just a little bit of a taster for people to get us thinking about some of this complexity and the fact that it is challenging for all of us to really get a firm grasp on the state pension age moving forward. So with no further ado, I'm going to move on here to introduce Professor David Blank. David and I have known each other for a long time now. He's wonderful, been a wonderful support to me and to ILC, and has been in many ways spearheading our work in the MISPA group. So David, over to you. 1 second, let me unmute you.
All this, the title about possible public health implications of raising the state pension age and how to mitigate them. You've mentioned what MISPA is. It's the acronym for Mitigating Increases in the State Pension Age. And we're just an informal grouping of 6 specialists in public health. So yeah, no, if you could do the next one, please, Brian. The background to our concerns is that the UK Parliament has increased the state pension age by 8 years for women and 3 years for men, so that both men and women will reach 66 years during 2020, 67 years in 7 years' time, and 68 by 2038. And of course, what Jenny Lyle would remind us in no uncertain terms is that by the time we get to 2038, it's quite likely that the nature of work will have changed beyond recognition. The UK Parliament has legislated these changes, but it hasn't reviewed the situation since March 2017, during which time there have been some big changes, which I would think justify them thinking again about the issue. The first big change in the last few years is there's now, I think, a fairly well-established consensus among actuaries and demographers that the life expectancy at birth is flatlined. And so it's possible that the change to 68 years will be the last increase this century. The second reason for thinking again is it used to be believed that any work is better than no work at all. And there's a series of papers become available using excellent data sets that show that physiologically, biochemically, poor quality work is worse than being unemployed. So it's likely to have a bad impact on people, particularly people who are already ill. And the third change, I think, is one that's been little discussed, but has come with this coronavirus pandemic. At the start of the pandemic, it was government policy and taken without much debate that people should work normally until age 68. But now under the coronavirus pandemic, we suddenly learn that anybody over 70 is at high risk and should be shielded. So there seems to be a bit of a contradiction here, and you wonder what happens between age 68, when you're supposed to be able to work like a youngster, and age 70, when you're supposed to be frail. So those have changed, I think, the situation. Next slide, please. The first of our unintended consequences is the problem of worsening the health of those who are already ill. When I started working in this area, it came as a surprise to me to learn that already there was a significant minority of people in the UK working beyond the state pension age, and that these people tended to be healthier and wealthier than their peers and to enjoy their work. What legislating increased the state pension age has done is add an element of compulsion to what was previously a personal choice, because in future, up until age 68, people will be subject to fitness for work testing and loss of benefits through sanctioning. So that's the compulsion. We estimate, and I would say it's an estimate, what we've done is used the best data we can get, mostly from the Office for National Statistics, and applied to that data fairly, what we believe to be robust assumptions. But don't pay too much attention to any particular number, but we think the order of magnitude of the numbers is pretty sound. And we estimate that by the end of this year, through raising the state pension age to 66 years, it will have added around 750,000 older women and men to the workforce. And at a very conservative estimate, 10% of these people, that's about 76,000, will report one or more limiting long-standing illness that may be worsened by an extended working life. And in terms of mitigation, we think this means that the health risks of extended working need to be medically supervised and the benefits of retirement for those in poor health recognized. Next one, please, Brian. Right, the second unintended consequence is overwhelming the sparse occupational health services and new demands on primary care, which already is creaking at the seams. Occupational health services remain outside the National Health Service, and only a minority of the UK workforce has access to them. And the ones who do have access are mostly those employed by large companies with their own in-house facilities and staff. The majority of the UK workforce does not have access to occupational health nurses or physicians because they're employees of small or medium enterprises, which lack such facilities. The proportion of SMEs providing occupational health support could be as low as 6%, with those employees on low incomes and working in areas of widespread job insecurity at highest risk. There's a classic inverse care situation that you're likely to have access to occupational health if you work in a large company in London or the southeast of England, and you're least likely to have access if you work for a small company in the north of England. And the classic form of mitigation in such a situation like this is triage. You need some evidence-based criteria that allow you to identify who needs to be seen first when you're trying to sort the 76,000 out of the 750,000. Next, please. The third unintended consequence is worsening the crisis in social care through loss of informal carers. Everybody knows if they turn on the TV these days that formal social care services already are understaffed in relation to the number of dependent older people. And in future, this situation is likely to get worse, and so that social care will rely increasingly on informal carers. And it's important to remember that the people who are providing this informal caring are mostly older people, mostly women, and often they're also supplying childcare that allows their younger relatives to take paid employment. So older people are going to be faced with the choice of which should they do, continue working or continue informal caring. And what we would like to see is the idea of work, people's contribution to society, being extended beyond paid employment to include also socially productive activities like informal caring and volunteering. So the mitigation is older employees who act as informal carers at the very least require flexible hours of work to accommodate fluctuation in the chronic diseases of those for whom they care. These are likely to, people will have good weeks and bad weeks, and if you're an informal carer, you'll be required, your help will be in greater demand when in the week where the person is not in good health. Next, please. The fourth unintended consequence is damaging the NHS and the charity sector through loss of volunteers. Volunteers support hospital employees in a ratio of up to 1 volunteer to 6 paid workers. And also they staff the many disease-specific patient support groups like Head Start for people with head injuries and what have you. Also, they staff many charities that are relevant to public health, such as the Citizens Advice Bureau, which gives access to health-related benefits, Age UK delivering Meals on Wheels, and a whole host of other charities like the Royal Society for the Protection of Birds, which provide a quality of life and access to nature. And these informal carers, like informal carers, these volunteers will have to choose between socially productive activity, paid employment, or volunteering. And one way of mitigating this would be certified volunteering should be recognized by the Department for Work and Pensions as a legitimate alternative to continuing in paid employment. Next slide, please. The fifth and last unintended consequence we want to mention is increasing the mortality rate of those employed in the most demanding occupations. This is something that's come out of an Italian project using a data set called the Work History Italian Panel Health Study. And they find that for each additional year of paid employment at older ages, the risk of the worker being taken to hospital with either a heart attack or a stroke increases by 2%, which may not seem large, but when it's over a long period of time, it cumulatively becomes quite significant. And also, it's within this study, they found that this relationship is confined to those who are employed in the most disadvantaged occupations, the people on lowest pay, the people on with the most short-term contracts, and so on. And in terms of mitigation, this finding needs to be tested for replication or not in other data sets. Is the finding a fact, or is it just an artifact of that one study? But this is, I think, a very potentially very important finding. Last slide, please, Brian. So, recommendations. We've identified 2 fairly straightforward strands of mitigation: commissioning research and fine-tuning administrative regulations. Research of 2 particular types. First, both have been mentioned already, establishing what are the evidence-based triage criteria to guide occupational health services, and where these are sparse or non-existent general medical practitioner services, in which employees are most at risk. And secondly, needs to be research is whether extending working lives will increase the mortality rate of older employees in the most disadvantaged occupations. In terms of administrative regulations, we think that there's a need to expand the idea of people's contribution at this stage of life, in other words, between ages 65 and 68, to include other aspects of socially productive activity beyond just paid employment. And I think that's the lot. I've tried to get it in not too long a talk. Thank you.
That's great. Thank you, David. Thank you so much. And as David sort of outlined there are, we as a group have identified various areas where something that's simple and straightforward, like raising the state pension age, and something that makes a lot of sense given the context of longevity, given the competing pressures around fiscal sustainability of public pension systems, given trends we've seen in other advanced economies. This increase to the state pension itself makes a lot of sense, and it's something we want to see put forward, but only in a way that doesn't then create other damages to people, their health, and consequently also the broader economy. I've got one more poll on this to send out for our attendees and participants. And this is primarily of those 5, you'll see it live now, of the 5 areas we've identified, we just wanted to get a sense of what you as the audience think is the area that is most striking to you, most worrying, concerning, just to sort of, again, get a sense of, for those of you who may be new to this or who at least haven't been part of our informal group, try to get a sense of the balance of importance or so perhaps even surprise that some of these areas may be unintentionally impacted by the policy reform around increasing state pension age. So about half of participants have voted. So I'll leave it open a few seconds longer. There we go. A few more seconds. All right. So I'm going to go ahead and close it in just a second. Let's see. Right, so I'll share this, and almost an outright majority have gone for that final one around the increasing mortality with disadvantaged occupational groups. And I mean, this one is of stark relief in some of the news that came out yesterday or this week with respect to the COVID-19, the work showing that mortality seems to be higher for people who are working in more of the disadvantaged occupational groups. And in fact, I've worked with other researchers at UCL and then other universities publishing a paper talking about how the sort of occupational category and the status of health are sort of interact with respect to the timing of retirement, to say that those in more disadvantaged positions, again, are less likely to see the sort of fuller benefits of longevity that we see on aggregate. So I'll stop that. And we will be moving on next to Claire. And Claire's going to provide us, I hope I get this right, Claire, provide us with a little bit of insight from some of the work she's done as part of MISPA to engaging with the WASPy women, whom you may have heard of. So Claire, go ahead and share your slides, if you would.
Thank you. Thanks, Brian. Thanks, everyone, for joining us today. Just share my screen now. Okay, so hopefully you can all see that. So as part of the MISPA group's report, we wanted to gain a bit of insight into some of the stories from people who are experiencing difficulties relating to increases in state pension age at the moment. And so we reached out to the Women Against State Pension Inequality group, which is acronym WASPI. And as it says on the screen, the aim of the WASPI campaign is to achieve fair transition pension arrangements for women born in 1950s affected by the changes to the state pension law. And you can see their website there if you want more information. So this was just women. We acknowledge, obviously, men are also seriously affected by this. And this is just a small amount of people that we were able to include for some personalization of the issue. So this is from the report, this page. So it's a section called In Their Own Words. And so we asked some women to give us their case histories, and which you can see on the screen now. And I've highlighted some areas just for a brief discussion. So we have areas highlighted in green and in yellow. So I have this page, which suggests that the yellow highlighted areas suggests what David was pointing to in terms of people having to choose between informal caring responsibilities and work. So there's a quote here from Janet Kane, who kindly responded to our request for information, who says that she relocated to Gosport, 18 miles from her family in Surrey, in order to get a job in a call centre and find cheap housing. Until that point, she'd been staying at home with her mum. She'd been a stay-at-home mum, working part-time and helping at school and being a carer for her mother, who died at age 62 after retiring at age 60. So that shows someone who has had to choose between these two responsibilities. Again, on the second page, there's two more highlighted in yellow. So Julie Rhodes states, I feel I shouldn't be forced to work to 66. When I do finally retire, my grandchildren will be grown up and I have to miss their young lives. So she's having to choose between work and being able to care for her grandchildren. And again, we had an anonymous contribution who says, since 2017, I've been the main carer of my parents, now 95 and 98, who are housebound. And I'm also a cleaner and a holiday let 2 days a week. So this woman's actually juggling both of these responsibilities. And then we also have some areas highlighted in green, which talk about people's experience of ill health and having to work whilst they're experiencing ill health. So we have Julie Connell, who says, I've never had any mental health issues, and this came as a complete shock to me, as I was always a strong one. Marilyn Jennings talks about having to leave work at 61 due to illness, and the stress due to that, and not being able to afford her basic necessities led to her having a heart attack. Janet Kane again says that she had a very stressful job in a call centre, which led to a breakdown, as well as her physical health problems such as arthritis, high blood pressure. Julie Rhodes talks about her struggle with arthritis and other health issues, her impact to work. And we have a contribution here from an anonymous person who says that the impact of her work caused anxiety and stress. So employers are now asking employees to do a lot more work with a lot less breaks. And most people that she works with, mainly women, have stress related to their physical and mental health problems. Again, anonymous CB. This lady has had manual occupations most of her life, and this has led to having painful joints such as her knees, her feet, her ankles, which swell after she's been working hard. And finally, Zoe Foster talks about working in the NHS for 42 years, and that she was unable to continue because the pain caused due to her feet during long shifts and her pre-existing arthritis. So those are just a couple of stories from women on the impact. That's all I have to say.
Thanks, Claire. Yeah, that's great. And I like the fact that, you know, while on the one hand, there's sometimes there's a bit of controversy around what the WASPy women as a group are calling for, often perceived as sort of fighting against these increases to state pension age. You know, I think we have to recognize that within the context of the reality of longevity, these increases are not only legislated, but they do provide some fiscal sense, helping to think about the public purse in the longer term. But what those stories from this group highlight in particular are some of the issues that are precisely what have to be mitigated in this context where state pension age is being increased. Without the proper support, the purpose of state pension age increase, having people work to a later age, won't be achieved because those people will have to fall out of the labor market regardless. And even the work I did 2014 with ILC on the missing million, that identified the number of people falling out of the labor market before they even reach state pension age. So again, I think that, you know, those messages, those experiences that we've highlighted by talking to the WASPy women really contribute to this debate. So now I'll move on to Jessica Sheringham, to give us a little more perspective from the public health world. And I think you are going to talk to us about some of the implications in the coronavirus context as well.
Can you see my screen? Am I sharing?
Yeah.
And I'm just going to resume slideshow. So thank you very much for the opportunity to talk today, Brian. The first thing I'd like to flag up is that we are dealing with a situation with so many unknowns here. So not only do we not know what some of the answers are, we don't know what some of the questions are either. So everything that I say here, I'm put here really as a point to open discussion. And I think from what we are learning already about coronavirus, when I reflected back on the messages that David shared and the things that are concerning all of you, I can only see that the impact on these things is going to be greater. So I've picked up on 3 of the issues that David raised. I think the first one on worsening the health of those already ill could equally apply to increasing the mortality of those in the most disadvantaged groups. So what we're seeing is, I think it is a given that COVID affects those disproportionately in older ages, and it is socially patterned, with deaths being greater amongst people and amongst those in working age of those in lower skilled occupations. I think the statistics this week from ONS showing the disparity in deaths amongst taxi drivers, bus drivers and security guards versus high skilled occupations really underline that. So we know from the research that David's presented to us that those in lower skilled, those in bad work, this is bad for your health, and coronavirus just seems to accentuate that. It might even increase the range of those jobs that become risky to health as well. The second impact is on the impact on carers and informal health and informal care. So one thing that we don't yet know about is the effects of COVID on the prevalence of long-term conditions. Even in those groups that are expected to be at low risk of coronavirus, such as, for example, children, those children that have been infected with coronavirus, apparently we are seeing quite significant changes in their lungs. So David gave his conservative estimate of the proportion of people reaching pension age that are likely to be affected by limiting long-standing illness. I suspect that the prevalence of long-term conditions is already higher than David's estimate, and that coronavirus has the potential to increase this in two ways. So firstly, directly by long-term damage to the lungs and increasing the risk of long-term lung conditions, and indirectly as well through the lockdown leading to effects in other ways. So for example, we've heard about the health service disruptions affecting reducing people's presentation for stroke, delaying diagnosis of cancer. And we expect that the constraints on our ability to adopt healthy behaviours will also be socially patterned, where you don't have access to your own gardens, your own outside space, and where the incentives, the headspace even to seek active lifestyles and healthy behaviours aren't there. And thirdly, David's talked about a number of different strategies for mitigation, and some of those I think we could argue are going to be even more important post-COVID. But we have also heard about, we're all living through the effects on employers of coronavirus, and this may lessen the ability for workers to negotiate working conditions for older workers in this time of insecurity. We could also argue that actually it increases our need to maintain a healthy workforce. So maybe these things become even more important and we can't afford not to do those. But I guess it's one of those things that we're in the balance of here. So I've presented those three areas really for discussion and really acknowledging that these, we don't know these effects yet. But I welcome the opportunity to talk about this, given that I don't think we can talk about any subject at the moment without reflecting on this new context of coronavirus. And I'll hand back to Brian there.
Great, thanks so much, Jessica. We're going to be shifting now to hear from Mel, Professor Mel Bartley, who's who's there sitting with David now. So Mel's done some work on, that you were saying a long time ago, around understanding the social policy process. So over to you to tell us what we need to do moving forward.
Well, I really just wanted to comment on what an amazing experience it's been for me to participate in MISPA. It's not my area of expertise. I'm a social epidemiologist, but I don't have any specialism in aging. I just kind of got drawn in because of my, well, in some ways it's an old interest, and in some ways it's a new interest in understanding how scientists and researchers can make sure that their work comes to the best effect and is as well used as it can be for public benefit. And many years ago, I wrote my thesis on the relationship between research and policy, and I kind of almost accidentally discovered that if a scientist wants their work to have, a researcher wants for their work to be useful and effective, nowadays this is called impact, okay? And it's kind of part of your evaluation, whether you keep your job as a university researcher or if you get promoted or whatever, which rather vulgarizes it. 30 years ago, when I worked with social policy experts who were very committed to the eradication of poverty and disadvantage, they were very concerned about this kind of thing because they actually wanted their work to be for the benefit of people in difficult and tough situations in life. And what turns out in a way, I'm just saying things that very successful policy and clinical scientists, they already do this. It was just that I had some time to go around, follow them around, talk to them, and document how they enabled their work to be best used. And what I found was that there was what I call a policy process in which the scientist, the last thing you want to do is to be too concerned with other scientists. We all write things and we feel we compete with each other. We want to get in the same high impact journals, et cetera, et cetera. From the point of view of impact, that is totally useless, I assure you, because all anybody else thinks is, oh, well, we want to do better than that person. We're competing with them. We don't want to spread the word how excellent their work is. And so that although it's necessary for some researchers and scientists to enter this competition to get your work into high impact journals, from the point of view of public good, that is a complete waste of time. That what you need to have is a network of people, and this is what I think is so brilliant about your group, is you need a network of people who are taken from pressure group, interest groups, such as ILC UK, people who are representing the people in Parliament. So you need to be prepared to address select committees, which I know that MISPA is preparing to do with a special document. You want to address groups who defend the interests of working people, such as the trade unions, so that I know that MISPA has contact with Unite, which is the union that represents a lot of medical workers. You want to be in touch with organizations. You need to be in touch with professions, such as the Faculty of Public Health, which we have, fortunately, we have members on the MISPA group. And we also have Jenny, who unfortunately couldn't be here today, but who represents both public health and occupational health in terms of understanding what the implications of extending working life is going to be for employers, if you like. And the other thing, which I thought was particularly brilliant, actually, was that MISPA got in touch with, is it Mumsnet?
Working Mums.
Working Mumsnet, which I thought was a stroke of genius. Because a lot of women, in order to avoid the extra stresses of various kinds of domination in their working lives, a lot of working mothers set up their own small companies. And so Working Mumsnet is actually rather an effective communicator with small and medium-sized enterprises. And they're also very interested in the work of MISPA because they want to know how to deal with this whole issue of extending working lives and how to look after the health of people, of their employees. Small companies tend to take more care of their employees. They want to know how to look after the health of their employees as these people are obliged to carry on working longer and longer. I also think that the whole coronavirus issue has, I'm not quite sure what the appropriate group is here, someone else can comment on this. It's really thrown into high relief, and some work I've been doing with the Labour MP Debbie Abrahams on this. I didn't expect these two things to be related, but they ended up being related, on the universal credit and the problems that arise for health from these changes in the regulations for receipt of Social Security. That actually what this is trying to do is to get sicker and sicker people to remain in work. And at the same time, we know now that the coronavirus is actually particularly dangerous for people, not just older people, but people who have underlying conditions such as diabetes, asthma, et cetera, and yet at the same time, our Social Security policies are actually pushing these people to stay in work, which is dangerous for them, and it's dangerous for their workmates. Now, I'm not quite sure what the appropriate, I think Debbie's still on the Health Select Committee or something, but being sensitive to all these different interests is how you make sure that your research is not wasted, but actually has the best possible impact. And I just think that MISPA, I'm fascinated to watch how your group has done this and how effective they've been. So I just wanted to make a comment on that.
That's great. Thanks, Mel. Thanks so much. That last point, I mean, well, two important points I want to touch on to before moving over to question and answer. And for all of our participants out there, please do send your questions in. We've got a few that have been submitted, but more the merrier. We'll get them answered. We've got 45 minutes or so left in the webinar, so plenty of time. Mel, you talk about the need for bringing together these different groups and these different interests, and I couldn't agree more. I think that's one of the rewarding things for me with my academic background working at ILC, and the work that ILC does, bringing together different groups, talking and forging sort of productive coalitions. And I think I'll also take the chair's privilege to tap into that other point you made about the sort of conflicts with respect to universal credit as another example. The tendency, if that's the right word, about trying to push people who may have these underlying conditions and who may have illnesses into work, or to get them staying in work. There's certainly in many ways benefits for both society at large or the economy at large, and to different extent individuals themselves for having fulfilling work. We know this, and we want to facilitate fulfilling work for anyone who wants it, regardless of age. But I think that point is incredibly important in the context of our coronavirus situation, particularly as we start to think about what's going to happen as we move out of lockdown, and the idea that if moving out of lockdown must be a gradual process, must take into account susceptibility to risk to the virus or ill consequence from infection. It may very well be that we have to be more nuanced in recognizing that people with underlying conditions we may need to think about how to open up from lockdown while making sure that those people stay supported without increasing their risk. I think it's a really important consideration.
Yeah.
So Claire and Jessica, Jessica, if you can unmute yourself, we are going to start addressing some of the questions from the audience, and I will be moderating this. So there's one quick question here. I'll take it to you. I'll send it to you, David, just to, if you have the answer, because I know it was Chiara who worked on the Italian study, but there's a question about how did the 2% year-on-year increase in heart disease and stroke compare with the year-on-year health changes for people not in employment? So suppose, was there a sort of, to what extent was the in employment factor accounted for?
Good question. I don't know the answer. I would guess you would have to go back and look at the publication. It's just been accepted for publication in a journal called Industrial Relations. Chiara Ardito is the first author, Ardito, from the University of Torino. I'm sure the details are in the study, but I can't remember. Sorry about that.
No, that's a very good. Here's a question. I'm going to paraphrase a bit. Oh, it disappeared. Yes. A question that relates to the balance in policy between health and employment. It's asking, how much do policymakers understand these problems for each generation, because the data don't seem to acknowledge this at times. Claire, do you have any insight on that, about sort of some of, I suppose, these generational differences in health, how they relate to employment?
Yeah. It's a good question.
Yeah. I think there's on the one hand, you know, we've got like you presented with talking about the WASPy women, you know, a lot of this work around that we've been doing on the increase to the state pension ages, you know, in that area of older workers, looking at sort of employment in later life. And, you know, yet we know, particularly when it comes to health effects, that there is a life course concept going on here. COVID, for example, the financial crisis from about a decade ago, you know, there are severe questions around whether or not they're causing scarring effects. With you know, when you talk to when you talk to the WASPy women, for example, do you recall any you know, that sort of awareness among themselves about how things have been for people that came before them, or any concerns that were raised about today's younger people?
Yeah, I didn't get a huge sense of before and after. I mean, I would agree. I think there was a big sense of the life course kind of accumulation for them in their lives. So, for instance, you know, one of the comments was around, you know, long-term manual occupation work and how that's had an impact on her health specifically, and caused many issues that are making her working for longer difficult. So I think in terms of her individual life, that's been a real issue. But I didn't get a sense of what came before or after from those comments.
We've got a sort of alongside that, or in conjunction to that, a point from Sarah Bickerstaff. Hello, Sarah. You know, this just, you know, underscoring this point that not only that here it's simply that health policy isn't joined up to employment policies, and the sort of inherent challenge there is to, you know, I suppose sufficiently address or tailor, modify, reform either of them in isolation. So Jessica, do you have thoughts on that and some of those challenges from the public health hat on?
Yeah, I think I was also reflecting on Alison's question about exacerbating workers who are vulnerable already and the impact on their health too. And, you know, if we're thinking about it in the current context too, I think there's the sense of vulnerability in two ways, isn't there? So the clinical vulnerability. My sense is that in some ways we're better able to think through the clinical vulnerability. It's the social vulnerability that we seem to be struggling more with. So if someone has a defined long-term condition, or I think, you know, one shift, kind of cultural shift now, is that I think it's more socially acceptable to stay at home if you've got a virus than it might have been a year ago, where that sense of presenteeism, I think, would have been more important. The data that we seem to be hearing about are that the problems are exacerbated for those in insecure employment and for those where in lower skilled positions too. So I'm not sure that directly answers the question, but I guess there's some of the things that are going through my head there. I'm
curious if you want to elaborate on that idea you mentioned about, you know, a good sense of understanding clinical vulnerability and, you know, relative poorer performance around understanding social vulnerability. I don't know if you want to elaborate on that just for a minute, but it makes me want to ask the question, does that sort of separation between the clinical and the social, is that also reflected in some of the disparate communications or conversations that, you know, that see the NHS in one group and the social care in the other?
I think so. I see David and Mel's were buzzing there. Were you going to speak, David or Mel there?
No, but I will if you like. What often it seems to me is that doctors still basically regard the patient as a machine. They're interested in doing things that fix it. Where fixing it requires the patient's motivation, then there's a temptation for doctors to hand the care over to someone from another profession, the nurses, the physiotherapists, the speech therapists, and so on. That doctors are better at, more like car mechanics, I think is how they regard themselves, whereas the other health professions are more like motivators, more human. I don't know if that's an offense against my own profession, but it's something that has struck me. For example, I cut my thumb off washing up a while back, and I took it to UCH accident and emergency, where I got fantastic treatment. It was all stitched back up and everything, and then I was just left, and I was passed over to the physiotherapist, who was gave me the courage and the motivation and the bravery to keep starting to move it again. The surgeon thought they'd done their job by stitching it up. Getting it working again was, as I say, handed over to the physios.
I'm going through our questions here, and there are a couple that I think might be related. And I'll turn first to Claire, but everyone else join in too. Claire, do you have a sense about it? In a way, the question is, what do we do? But I'm going to focus it particularly on this one around where someone's asked if a longer transition period for the increase in the female state pension age would have helped its implementation. And I'll also comment on, that there are different arguments, different perspectives around how well informed the women who were impacted by the latest changes to state pension age, how well informed they were, and how the kinds of informational materials sent to them. There's a lot of evidence suggesting no matter whether they were actually sent information, how well they understood it, and whether or not they were prepared. But from the quotations you cited, Claire, there's certainly this reinforcing the question of the health situation. So do you think some of the issues that perhaps the WASPI women themselves put forward, or as part of the broader debate as we see state pension age increase for both men and women, do you think this has been, to what extent do you think this has been an issue of it being rushed or a short timetable, or do you think some of the fundamental challenges actually lie elsewhere, say with the health?
Yeah, I think it definitely came out from what the women were saying, that they were shocked by the sudden change in policy, and for them they felt there was no warning. So as you said, there's debate around that, but for them, their experience was that they didn't have enough time to grasp this. But I think it's also so I think maybe a longer period could be useful, but I think it speaks to a more fundamental issue of, I think, firstly, the juggling of different roles for men, but particularly for women, seems to be really strong, especially when they get to that age where they have got this different aspects, say, of informal caring, as well as the employment, and that burden becomes heavier. So I think that wouldn't really be addressed by a longer period of time implementing policy. And also, you know, for a lot of these women that have been working for a very long time in very stressful occupations, some of them quite physical, not always, but quite physical, or poor working conditions. The toll of that has been tremendous, both on their physical health, but particularly on their mental health. You know, those are fundamental issues, I think, that aren't going to be addressed by a longer transition. They'll be addressed by better working conditions, better, possibly, you know, occupational health services for women. And as we've mentioned, as David mentioned, you know, recognition for other contributions to society, you know, such as informal caring and volunteering and these other things that these women might feel more equipped to do it at this point, rather than continue with paid work.
Yeah, we've got a few, again, as a sort of theme running through a lot of our questions, that point precisely around the sort of unpaid contributions, potential need to rethink how, you know, what we categorize as, you know, productive, because so you know, one attendees asked about the panel's view on unpaid work, women's, they've got in parentheses, being accounted in GDP, and how that might contribute to pension contributions. I'm right in saying, I believe, and David, I think you'll know, that sort of the qualifying quarters that account for, that contribute to how much you'll get for state pension, there is a allocation for time spent providing care. Is that right, David?
You keep asking me questions I don't know the answer to.
Just so challenging.
Yeah, another thing I'll look up.
Yeah, I'm pretty sure that's right. But I mean, you know, I think, you know, you know, I'll take it for whomever wants to respond. I mean, this is an interesting question to me about, you know, whether or not there are other things that can be implemented in policy, or in particular policy evaluation approaches, where we move beyond just recognizing the paid employment elements that exist within society to in a way quantify these other unpaid contributions. I mean, would that make a difference? I mean, again, David, not to put you on the spot again, it sort of makes me think about the sort of potential ways of mitigating what's happening, what potentially could happen with declines in volunteers. Because again, they're making an important contribution in many ways, like what would otherwise be paid work. How do we value that as a society?
Well, I don't think it's a coincidence. I came across this idea of socially productive activity from a German colleague. And there, the rates of volunteering in Germany are much higher than in the UK. I guess it's part of the tradition of civil society, which it used to be fairly uncontroversial, that it is largely atrophied in the UK, but I think recently this coronavirus pandemic has showed that it's actually alive and well. It's just been lying dormant. So for me, one of the many things I learned from Jenny Lyle is that for the last 20 years, it's been good practice within occupational medicine to argue that, or advise patients that they should take a gap between leaving full-time paid employment and deciding what to do with the rest of their lives. A sort of a period of life which within the current context could quite easily fit in the gap between the years of age 65 and 68, where a person has 3 years to try out different things. You know, it may be they want to stay in paid employment. It may be they want to take up informal caring. It may be they want to volunteer. It may be they want to retrain for something new to do for the rest of their life. You know, at the moment, there's a problem that if somebody at age 65 asked for a student loan to start a university degree, it would just be turned down flat. It's just not possible. Whereas, you know, a lot of people at age 65 live wires might really enjoy to do, learn some new skill, new trade. So I think it requires a bit of imagination and not too much sort of, I dislike, I think, in principle, the idea that people between 65 and 68 should be subject to fitness for work testing and potential loss of benefits. I think that's, after a lifetime of work, that's really not the spirit in which you're going to encourage people to prepare for the rest of their lives. You've got to give people the chance to think what they'd like to do. I mean, it should be quite acceptable that if someone's in poor health, that between 65 and 68, they should just be allowed to rest and recuperate and try and heal up after an arduous life. So it requires something a bit more generous, a bit more encouraging, a bit more like the physiotherapist with my damaged thumb. You have to give people the chance to heal up and motivate them to try new things.
Brian, I guess there are two things. One thing that's sprung up for me from what David's been saying, talked about the policy, you know, what are the lessons of policy? I guess I'm wondering about the levers for encouraging flexibility for employers. And maybe that is, you know, maybe there is a silver lining we can draw out of COVID in that respect. And that actually is to set a great precedent for working flexibly and working in different ways. So, David, you reflected on what we've learned from Jenny as well. One of the things I've also learned is about the transition to retirement starts well beyond the week, you know, planning your retirement party. So it's becoming more commonplace, certainly in the health service, to look at transitioning roles. So a GP may go from, instead of stopping working as a GP, delivering consultations full-time, they may transition into a more mentoring role that really maximizes the benefits of their huge experience, but actually isn't quite so grueling on them in their later years of practice. And I'm just not sure how widespread that is, or whether there is any research looking at the impacts of that flexibility on health of employees. And that would be something that would be rich to explore as we go forward. And Brian, you'd mentioned about what did I mean about socially vulnerable, and I guess I was thinking about those people particularly with caring responsibilities. I was thinking that in Germany, amongst those people that they've bracketed as vulnerable are solo parents, and they have things like access to childcare places in the same way that key workers do during their coronavirus. Whereas in the UK, that is certainly not something that's considered.
Yeah. Because I think, thinking back, for example, David, your comment about, facilitating some sort of gap between the exit of full-time employment and making a decision about what happens next. You know, Jessica, you just mentioned these levers for encouraging flexibility, facilitating like transitioning roles. You know, this all comes back, I think, to a message, you know, most of us, if not all of us, would agree with, around facilitating people to make the positive choices for themselves with respect to their engagement with socially productive activities and or the labor market. But that, I think, you know, we have to pause in a way to think about, as the fifth point, the fifth area that you mentioned, David, around in your presentation about sort of that relates to disadvantaged occupational categories. It brings back a question of how to ensure these opportunities exist for everyone. We've got lots of questions, you know, in our in the Q&A box here that relate in one way or another to you know, ensuring that the future, how do we address accessibility questions and the challenges there, sort of mental health considerations, ageism, the, you know, the discrimination that happens among older people with, you know, within the labor market. Again, an area I know very well. And I suppose it all sort of comes back, Claire, if we want to try to think about what we do moving forward. You know, with again, putting you on the spot with the WASPI women, I mean, to what extent has that sort of, have their experiences given us lessons about how we might help the different groups be better prepared? Or might you say that the WASPI group is self-selective in that these are those who have, you know, the ones who didn't fare through the process as smoothly as others?
Yeah, I believe that their stories, although it's not obviously a hugely representative sample, I believe their stories are you know, speak of a wider issue and what other people are going through out there. I think human resources could have a much bigger role in supporting people throughout their working lives. So not just when they're getting close to retirement, but whatever age they're at, in terms of supporting them with any issues they're going through at that point, and also cultivating more kind of positive mental well-being. So I followed the work of CIPD, which is a HR think tank, and they've produced a lot of resources around worker well-being throughout the life course. And I think those kind of more preventative approaches, so people don't end up in a position where they are having burnout or a breakdown, or, you know, which is both mental health but also intertwined with their physical health, that those issues can be dealt with early on, so therefore they can have more productive working lives and possibly work for longer. So I think HR is a huge role to play, alongside other partners, of course.
Yeah, I mean, you know, that message is one ILC continues to put forward in some of our other work, that message of the importance of prevention and ensuring, you know, doing what you can to stop you know, negative progress, or to stop negative conditions from materializing in the first place. And that in a way links here, I don't know if anyone wants to answer it specifically, but about sort of recognizing that again, I think this is being asked in the context of our lockdown situation, but, you know, consequences related to malnutrition, for example. How, you know, what do we, you know, how, when we're thinking about the kinds of the different needs of different groups, their potential to be in different disadvantaged positions, I mean, what role does ensuring, you know, access to quality nutrition plays in all of this? Does anyone have any insights on that?
A couple of things.
Yep.
One is that the Institute for Physical Studies the other day had a webinar on the COVID pandemic. And one of the speakers was the last year's Nobel laureate for economics, Angus Deaton, who had dug out a paper from nearly a century ago that listed the contexts in which profound social change tended to occur. And one of the four types of situation was fatal pandemics. You know, we should not underestimate the possibility of the situation. I mean, who would have thought that the government that was recently elected on a basis of leaving the European Union would behave in the way it has in terms of furloughs and the amount of money and so on that they put into the economy. So, I mean, this might be a good time to be asking such basic questions about where we, you know, how things are going to evolve in future.
And we don't really have, you know, one of the questions, I just want to sort of make it explicit and welcome the other group members' perspectives. One of the questions is whether or not here, when we talk about recognizing the value for involuntary work and informal carers, whether or not we're suggesting that people, in addition to flexible work or instead of flexible work, they get to claim their pension age earlier than the new standard ages. Now, my perspective, both sort of individually and as you know, representative of ILC, is that, you know, these legislated changes are legislated, so they're our reality, and we deal with them. What is more concerning is when it's just made and these other issues that we've identified around needing to support people for their health or needing to make sure that there are sufficient support services available in terms of occupational health, for example, that's what we need to focus on, rather than starting to get too bogged down by a specific age and a specific eligibility threshold. But I'll turn it to, I mean, David, Claire, Jessica, I don't know if any of you have a specific perspective on whether or not there needs to be greater flexibility in the age at which pension is received.
One of the things that struck me is if you look back over the decennial censuses, I did this in the context of using the ONS longitudinal study, which started in 1971. And if you look at the 1971 decennial census answers, women, the great majority of women describe themselves as homemakers or housewives or what have you. The proportion of women who describe themselves in terms of the labor market was very small. By 2001, you look at the answers to the same questions, and hardly any women these days describe themselves as homemakers or housewives. Mostly, the great majority of women are describing themselves in labor market terms, either in paid employment or early retired or unemployed or permanently sick. So I think that, and what struck me is when you look over that period from 71 to 2001, is that men and women were going in opposite directions. The proportion of women who saw themselves as workers within the labor market was going up, whereas the proportion of men who were leaving the labor market early was going down, it was increasing. So women were staying in the labor market and men were getting out earlier. So I think that in a sense, for women's state pension age to become the same as men's, it's really fits very well with what women already appear to want. in terms of their labour market position and how they see themselves. So I think I don't know. I mean, well, I don't know. I guess it's an empirical issue,
Yeah.
but it seems to me that you can make a good case for the pension age being the same for men and women, and where you draw the line, where you say that is, I guess that is you could negotiate over. But I can't see a strong case why it should be different for men and women. I think women originally had an earlier state pension age than men because they wanted women out of the labor force. They didn't want women to compete with men for jobs.
Potentially, depending on the historical context, facilitating their ability to provide informal care for their husbands.
Yeah,
potentially. You know, we're sort of running out of time here. I want to give everyone, all of our panelists, a last opportunity to make comments, and so we'll start with Jessica, go to Claire, and then finish with David, and Mel. Not going to ask you to answer a specific question. Feel free to summarize your final thoughts. But there are plenty of questions that the audience asked about relating to some of the proposed shifts. For example, around you know, as in the context of COVID, as we move out of the lockdown, this context of staggered shifts, it makes me think about some of the negative health implications that that research has identified for people who work third shift, for example, and those sort of the asocial shifts, and whether or not that will have an implication. Questions around culture and diversity with respect to the health service, learning disabilities, mental health. So there are lots of topics that we can all you know, spend ages and ages discussing. But Jessica, I'll turn it over to you for some final comments.
So I think to emphasize my main message from what the public health implications in the context of COVID, I think the unintended consequences on the state pension age have the potential to be even greater. However, picking up on the discussion and David's point about the potential for significant social change, I think going forward, I'd welcome the opportunity to consider in MISPA and beyond what opportunities we can seize from these changing tides to look at other ways to mitigate the changes and their effects on health.
Great, thanks. Claire?
Yeah, I think it's clear from the work that we've done that we need to be thinking about not just people who are reaching retirement now and supporting them, but about the longer term life course of people's working lives, and particularly the inequalities. So in the poll, the biggest concern for the people, for the participants, was around inequality and mortality. So, and those things are generally, you know, occur over a very long period of time. They accumulate over years and years. So making sure everyone has the best access to support in work and also other services provided by the state is really important, and to reduce these inequalities and hopefully to mitigate people having to leave work early or struggling to continue to work till they're 68.
And David and Mel.
One thing that the issue of the state pension age shares with the coronavirus pandemic is that it is international. And many of the issues we're talking about in relation to the state pension age in the UK, you would hear very similar discussions in Switzerland, Italy, Spain, France, Germany, Finland, Norway, Sweden, and Belgium, Netherlands. And we should remember to look at the experience in other countries in relation to how to just as we have even on the television every night, or until they did until 2 nights ago, they would put something about the situation in other countries in relation to the COVID pandemic. We should equally pay attention to what's happening in relation to the pension age in other countries. And here there is an example of why where the International Longevity Center is in a strong position, because it already has an international network. And that might be something we could consider using.
Absolutely. I mean, you know, you're right. For those on the webinar who don't know, we are part of the Global Alliance. So there are ILCs in 16 countries. But before I make my final remarks, did Mel want to come in and say any last words?
Mel says no.
Okay.
Thank you for inviting her.
Absolutely, absolutely. Yeah, just to sort of finish the webinar, I want to thank everyone, of course, who's been on and asked your questions, and apologies if I didn't ask your question in just the right way. But hopefully everything we've covered has been wonderful food for thought. And has helped you see some of the potential we see in the work of the MISPA group. Again, like David kindly sort of mentioned there at the end about ILC and our role and our ability to work internationally, we do have a partners program, and this provides organizations and businesses with our unique insight and business intelligence. It can facilitate greater connections with those stakeholders with whom we speak on a regular basis, covering government to the corporate sector, academia, and other policy experts. And it also allows you to be part of our club and get the brand benefits from some. So if you do have interest in that, please contact my colleague Redvers. His email there is at the bottom of the screen. And as a final reminder and a final plug, we do have our, this will be our 6th annual conference later this year in December, Future of Aging 2020. Our focus this year is going to be thinking about how we can move together for tomorrow and understand some of the issues that relate to generational differences, how to fight against some of the intergenerational conflict narrative, to deliver a better society for all. So this will be taking place in December at the Welcome Collection. Again, dependent on our situation with respect to COVID-19. Visit the website, and we do currently have an early bird rate. Visit our website for further information. Join our newsletter to find out about our upcoming webinars. This has been the 4th in a series that we plan to host every Thursday as we move forward through the pandemic. So just let me finally thank again David, Mel, Claire, and Jessica for sharing their insights. And thank you all for joining us. And have a very wonderful day and weekend ahead.
Thanks, Brian.
Thank you.
Thanks, Brian.
Take care.